Thank you everyone for joining us for this special post-election webinar. Dr. Gerald Kominski, Director of the UCLA Center for Health Policy Research and one of the nation's leading experts on health policy, will dissect the election results and talk about what it means for the implementation of the Affordable Care Act. We want this to be a dialogue, so we will allow plenty of time for questions. If you have a question, simply type it in the field at the bottom of the chat window in the bottom left-hand corner of your screen. And Jerry, I want to start out by congratulating you on correctly predicting that Florida would be the only state where the race would be so close that we might not have the results in time for this webinar.
Thank you very much, Carla, and welcome to everybody who's joined us today. So this is yesterday's election obviously was a historic election for healthcare reform, because what it means is that the Affordable Care Act, which has been subject to numerous efforts to reverse, overturn, delay the implementation of this law, now can move forward in a way that it might not have been able to had the election results been different. So what I'd like to do today, though, is to review the major provisions of the law and talk a little bit about what's happening in California and how healthcare reform and the Affordable Care Act is being implemented here in the state. So let me, some of these slides I've used in previous presentations about the law, and I'm not going to spend a lot of time reviewing all the provisions, but just to remind everybody, the law has three major provisions that include subsidies to make insurance more affordable, mandates requiring individuals and employers with more than 50 employees to provide health insurance benefits, and then insurance exchanges, which are the regulated marketplaces where individuals who are eligible for subsidies can use those subsidies to purchase affordable health insurance. In addition, there are protections now that have been in place for many Californians and many Americans who are currently insured, and many of those provisions went into effect in 2010 and 2011. Just quickly review some of the provisions that are already in effect. Probably the provision that most people have been affected by to date is the expansion or extension of coverage for adult children up to age 26. The estimates are that about 3.1 million young adults are insured today who would otherwise be uninsured without this provision of the Affordable Care Act, and that is a significant number, and we've seen in the national estimates of the uninsured that translated into a measurable decline in the number of uninsured nationally, from 51 million to about 48 million based on the most recent data. So this one provision alone has already had a pretty significant impact in reducing the number of uninsured, both in California and throughout the country. Other provisions that have already gone into effect include the elimination of policy cancellations, the elimination of lifetime dollar limits on benefits, and the elimination of pre-existing condition exclusions for children under age 19. And then finally, the elimination of restrictive annual dollar limits on benefits. Other provisions that went into effect in 2010 include the requirement that all new health insurance policies provide coverage for preventive services with no out-of-pocket cost to the policyholder, allowing pediatricians and OBGYNs to be designated as primary care providers, and the allowance of the use of ER services without prior authorization. So that sort of brings us to the provisions of the bill or the law that are yet to go into effect and will be really the heart of healthcare reform. An essential component of healthcare reform is the creation of standardized health policies. The law establishes that qualified health policies will need to be offered by insurers, all having the same essential benefit package. The language here that I've quoted is from the law itself, saying that the Secretary shall ensure that the scope of the essential health benefits is equal to the scope of benefits provided under a typical employer plan. The federal government has allowed a fair amount of leeway to the states to determine what the essential benefits will be in each state. And California, back in September, Governor Brown signed legislation that established the essential benefit package in California as being equal to the benefit package currently offered by the Kaiser Small Group 30 plan. And that plan is a $30 copayment plan that Kaiser offers. It's one of their most popular plans for small employers, and that has been adopted in California as the de facto standard for essential benefits. So all policies in California will be required in 2014 to offer a benefit package at least equal to what's in that plan today. And that includes coverage in 10 major categories of services. The plans that are going to be offered, these essential benefit package plans offered in the exchange, are going to have 4 tiers, and the tiers don't vary in their benefits. They vary only in the proportion of total benefits that are paid for by premiums versus the proportion of total benefits that's paid for by out-of-pocket spending. So the bronze plan, which is intended to be the most affordable plan, is a 60-40 plan. 60% of the covered benefits are expected to come from premiums, 40% from out-of-pocket spending. And the best way to think about that bronze plan is that it's going to be similar to high deductible plans that are currently sold in the health insurance market, but maybe with a little less out-of-pocket liability. High deductible plans today tend to be closer to 50-50 rather than 60-40. At the other end, the platinum plan, again, the same exact benefit package as the bronze plan, but premiums will be higher, but as a result, out-of-pocket spending will be lower. And the expectation is that that'll be a 90-10 split. And of course, there'll be these catastrophic policies that are available to young adults to keep insurance affordable for those under age 30. All qualified policies in the exchange are going to have limits on out-of-pocket spending, close to $6,000 for individuals and about just under $12,000 for families. And these out-of-pocket limits will be lower for people at the lowest level of the income scale, between 133 and 250% of the federal poverty level. The policies in the exchange are going to have to comply with guaranteed issue and renewal requirements and eliminate lifetime and annual dollar limits on benefits. The new insurance markets that we're going to have are the exchanges. There'll be 2 exchanges in states, individual and small group market. And of course, as a result of the Supreme Court decision in June, there is concern nationally about how many states will actually be ready to establish insurance market exchanges in time for enrollment a year from now, which is when the exchanges would need to be enrolling individuals in time for coverage to start in January of 2014. But I'll come back to this a little bit later. The exchanges can only sell qualified health policies with essential health benefits. And more importantly, the law requires that these qualified health policies be sold both in and outside the exchange. The law requires that insurers set the premiums using modified community rating. So the only factors that can be taken into account in the premiums is the age of the policyholder, tobacco use, size of your family, and where you live. Most importantly, health status will no longer be used and will be prohibited from, insurers will be prohibited from using health status to set premiums. The law requires or retains existing small group and insurance markets, but insurers who sell policies inside and outside the exchange will have to charge exactly the same premium. And this is intended to prevent insurers from trying to segment risk in the market by offering lower premiums, for example, outside the exchange than they do inside the exchange. The law has penalties, and as most of you recall, this was really the core of the Supreme Court challenge to the Affordable Care Act. The requirement that individuals either buy insurance or pay a penalty was upheld in June by the Supreme Court. And the penalties will start at $95 in 2014, and by 2016 will be up to $695 per adult, up to a maximum of about $2,100 per family, or 2.5% of household income, whichever is greater. There are also mandates on employers with more than 50 employees, in addition to the individual mandate. The law provides subsidies that are based on the cost of the Silver Plan for those with incomes between 139 and 400% of the federal poverty level, and those are on a sliding scale. And then finally, the law expands Medicaid coverage to anyone with an income up to 139% of the federal poverty level. And this was the provision of the law that was found unconstitutional by the Supreme Court in terms of the mandatory expansion of Medicaid programs. So as a result, states now have the option to expand their Medicaid programs, and as we expect, a number of states, particularly those that were involved in the 26 states that were involved in the constitutional challenge, are unlikely to expand their Medicaid programs, despite the fact that the Medicaid expansion is fully funded by the federal government for the first 3 years, and then ultimately will be covered by a 90% federal match by 2020 and in future years. Some of the ACA provisions that are already in effect is the Medicare Part D donut hole is being closed. That's scheduled to be fully closed by 2020, so it's a slow transition, but approximately 350,000 Californians who are Medicare beneficiaries have already received rebates. The ACA has eliminated cost sharing for Medicare preventive care, consistent with the requirements to eliminate cost sharing on private insurance. It's created small business tax credits to support employers with up to 25 employees and with average salaries of less than $40,000 per employee to qualify for tax credits to buy health insurance. The medical loss ratio provision of the law has already gone into effect, and those rebates were issued earlier this year. About 2 million Californians received rebates this year, averaging about $65. Premium rate review, which is one of the provisions of the bill, has gone into effect, and the states received about $1 million to strengthen its rate review process. The pre-existing condition insurance plan for people who currently do not qualify because of pre-existing conditions. About 13,000 Californians were enrolled in this program as of August. And then finally, the early retirement reinsurance program, which is provision of the bill that allows companies that have retirees who don't qualify for Medicare yet for those companies to extend health insurance benefits to their retirees until they qualify for Medicare. This program, however, is benefiting only a very small number of Californians based on current estimates. So what do we expect to happen in California? Well, based on projections that we've produced here at the Center for Health Policy Research, and along with colleagues at the Berkeley Labor Center, we think that ACA, when it's fully implemented, is going to increase the percentage of Californians with insurance coverage from about 84% today to approximately 89% under what we call the base scenario, which is where the exchange is sort of doing business but not necessarily engaging in extraordinary or additional efforts to reach out to the eligible population. But we think based on the exchange board's positions that we've also modeled what we call an enhanced scenario and expect that up to close to 92% of Californians will be ultimately covered under ACA or as a result of ACA. And this assumes that the exchange board engages in a very active campaign of education and outreach to its eligible population. And we think that that's a more likely scenario in California. Just to show you what those efforts result in regarding numbers, and I'm really focusing attention here on the two red circles. We think that the Medi-Cal or Medicaid expansion is going to result in a growth of enrollment of a little over 1.5 million between now and 2019 when the bill is fully implemented, and that there will be approximately 2.15 million people in the exchange receiving subsidies. Not all of those are currently uninsured. About approximately 1 million of those people in the exchange with subsidies will come from the current individual market where they're paying the full cost of those premiums out of pocket. And about 1.15 million of the individuals we expect to be in the exchange are currently uninsured. So I'd also point out that despite the availability of subsidies and despite what we expect to be very vigorous outreach on the part of the exchange, that at least according to our model, we expect about 3 million Californians to remain uninsured when the bill is fully implemented. About 2 million of those would be eligible for coverage but just not sign up for a variety of reasons. And then about 1 million are undocumented and therefore would be ineligible due to their citizenship status. So just to summarize sort of the formal part of my presentation for today's webinar, I think that the main conclusion of yesterday's election results are that California is in a position to move forward relatively aggressively with continued implementation of the Affordable Care Act. I know based on information that I've seen in the last just in the last 24 hours that the state is planning to have a special legislative session in December devoted entirely to sort of cleaning up some of the implementation issues related to the Affordable Care Act and its implementation here in California. And that would include enacting most likely some bills that the governor did veto earlier this year when there was uncertainty about the election results. But now that the president has been reelected and there's a clear signal that ACA implementation is going to move forward, it's likely that those bills that Governor Brown vetoed earlier this year will now be signed, assuming that the legislature passes them again, which I think is a very safe assumption. I think that what we'll see in the next 12 months in California is a tremendous amount of activity and on the part of the exchange board to begin to reach out to California's, to all Californians, to make them aware that the exchange exists, and then I would anticipate in the spring and certainly by the summer of 2013 that we're going to see a very intensive multimedia campaign to increase awareness of the exchange and what's its role is in healthcare reform, and to begin to recruit the eligible population both into the exchange as well as into the Medicaid program under the expansion. So let me stop my formal comments there, and I did have this one other slide, but let me stop my comments and open it up for Q&A.
Jerry, thank you so much. If you do have a question, please type it in the field at the bottom of the chat window in the bottom left-hand corner of your screen. Let me start things off, Jerry. You talked about the exchanges. Some states have yet to act to set up an exchange, and time is running out. They have just 10 days left, I understand, to decide whether to set up a health benefit exchange. What happens if they refuse?
States that refuse to create their own exchange, there's explicit provision in the law allowing the federal government to set up an exchange in states that don't comply. It's my understanding that the federal government is completely prepared to do that. And although there was some discussion earlier this year about, let me back up a little bit in terms of my response. I think everybody on this webinar is aware that there have been sort of unprecedented efforts to block this law at every step of its implementation. Part of that effort, once the Supreme Court decided that the law was constitutional, essentially all provisions were constitutional with the exception of the mandatory Medicaid expansion. Once that was decided, there have been a number of sort of secondary challenges to the law. One, and it really defies the imagination in terms of creativity on the part of the opposition, but one of the efforts that was surfaced after the Supreme Court decision was that perhaps if states did not create an exchange, that the federal government, when it created an exchange in those states, that the federally created exchanges would not be eligible for subsidies because the law, there's a provision in the law that says that subsidies are available to be used in state-established exchanges. And so some conservatives were interpreting that to mean that the law prohibited the use of subsidies in exchanges that were created by the federal government. I don't think that feels a little bit like a last-ditch effort to try and find a loophole, and I doubt that there's going to be any traction in that effort to try and subvert the implementation of the law. But I think that we could see at this time next year as many as half the states in the nation having a federally operated exchange as opposed to a state-established exchange. And then the question is, how long will those states allow the federal government to continue to operate the exchange, or will those states eventually come around and say, we really need to be involved in controlling this and having input into this process rather than having the federal government operate the exchange in our state? I should also say, related to that question, is that it's my understanding that at least 2 states, and perhaps as many as 4 or 5, enacted laws yesterday prohibiting anyone in the state from being required to participate in quote-unquote Obamacare. Again, I think that these are largely symbolic measures at this point. I'm not a legal expert, but I don't think that the states can enact laws that are in direct conflict with existing federal law, and I have a feeling that those laws will be quickly found unconstitutional.
We have a question from Carrie Katz asking if there are any current projections for what employer group medical increases might be.
I don't think that there are, because I don't think that the Affordable Care Act directly affects most of, certainly the large group market. Now, having said that, you know, that some of the provisions of the law have some marginal impacts on the cost of group health insurance. But if we sort of separate the large group from the small group, large group market, I think, is largely unaffected by the Affordable Care Act, and therefore whatever increases are going to occur are driven by factors that have nothing to do specifically with the law. In the small group market, because there will be the shop exchanges, and they're more the law directly affects the small groups, the small group market. It's a little unpredictable. The essential benefit package that is likely to be adopted in other states, just as it was in California, is based on existing policies that are already offered in the small group market. As a result, if that ends up being the benchmark policy or the qualified health plan, I think we could expect the cost of that to be similar to what it is today in the market, and as a result not to be more or less expensive. So I'm not aware of specific forecast about what is going to happen to health insurance premiums directly related to the Affordable Care Act, but I think it's clear that some employers, especially in the small group market, will find more affordable choices, and in some cases there may be less affordable choices than are currently available, simply because employers today can offer very narrow benefit plans that won't be acceptable in 2014.
A question from Chris. You mentioned about penalties imposed on individuals who choose to not get insurance. How will the government identify these individuals to hold them accountable?
Well, that's the $64 billion question. The answer is that this is the one loophole in the law that I expect to be the next one of the a cause célèbre for the conservatives who are opposed to the law. The legislation says explicitly that the Internal Revenue Service cannot prosecute individuals who fail to pay the penalty. That's another way of saying that there's a loophole in the penalty for individuals that is enormous. I think that this is not necessarily widely known right now. I expect as the opposition runs out of options that this will be one of the last remaining ways of defying the law that will be brought to the public's attention. And my guess is that it will be prominently featured on certain websites and certain quote-unquote news organizations that continue to oppose the implementation of this law.
Matthew wants to know what sort of quality metrics and or standards might be required for health plans to participate in the exchange.
That's an excellent question that I don't know the answer to yet, but I do know that the Exchange Board is very interested in being not only a one-stop shopping place for individuals to buy health insurance with or without subsidies, but I think that they view themselves as helping to drive the market in California. So I think that the the California exchange is going to be a place where you're going to find not just comparison shopping on price, but on various quality metrics. And I think that not only on their website, but in the information that they provide to consumers, they're going to make quality metrics of the sort that are available to us, many of us today when we go through open enrollment, to make those widely available on the plans that are going to be offered through the exchange.
A question from Ken. He asked, is there any direct regulatory connection between efforts to create accountable care organizations and the implementation of the exchange?
The short answer is no. The provisions in the bill that promote accountable care organizations are largely tied to Medicare beneficiaries. So what the federal government is doing to promote ACOs is, because it has spending authority and responsibility for Medicare beneficiaries, it's using the Medicare program to promote ACOs with the expectation that innovations that occur in the Medicare population can spill over into private insurance and into the Medi-Cal program or the Medicaid program nationally. So there aren't direct requirements or direct links outside of the Medicare program, but I think that that expectation of positive spillover effects is sort of the underlying rationale that went into those provisions.
A question from Tom Rice. He asks, where do things stand regarding subsidies for people below the poverty level who live in states that do not choose to expand their Medicaid eligibility rules?
Yeah, that's a great question, Tom. I think that those individuals are in limbo right now. Just to clarify, if a state doesn't expand its Medicaid program and yet the law provide subsidies for people above 139% of poverty, but let's say the state's current Medicaid program goes up to 50%, they choose not to expand up to 139%. What are individuals going to do in that corridor? They can't qualify or sign up for the Medicaid program in their state, and yet they're not eligible for subsidies in the exchange. I don't, to my knowledge, that issue has not been resolved at the federal level yet. One option would be to expand or extend subsidies for individuals, but to my knowledge, that has not been decided yet.
A question from Zenaida, and I apologize if I'm not pronouncing your name correctly. How will this affect the present MMRIP and the PCIP programs that are ongoing?
Well, I think in 2014, when pre-existing condition exclusions are no longer allowed for adults, that those programs become less necessary. So, because there'll be other lower cost options available to people.
Mark Wells asks, he says, we're hearing that the House of Representatives may not authorize funding for some or all provisions of ACA. What are these provisions, and what would the impact of non-funding be on the implementation of ACA?
Yeah, that's a great question. First of all, the House doesn't have the authority to deny solely on its own. So one of the questions moving forward will be, to what extent are provisions of the bill subject to ongoing budget resolutions or budget reconciliation processes between the House and the Senate. I don't know all of the provisions of the bill that could be subject to withholding of funds, but it's my understanding that the subsidies, which are a core portion, in a sense, perhaps the largest, not only single source of expenditures, but in a sense one of the core elements of the law, that those subsidies are subject to ongoing budget discussions between the House and the Senate. And so they are potentially vulnerable, and it's my understanding, moving forward. And it will be important for Congress to decide on an ongoing basis how to support those subsidies that are authorized in the law.
Valerie asks, do you believe that the California exchanges will be successful in terms of membership growth and sustainability?
I think that it will be successful. I think that, but it depends on the sustained subsidies from the federal government. Health insurance is an extremely expensive product, and that's why we have such a high rate of uninsurance both nationally and in California. The Affordable Care Act, because it provides subsidies and expansion of the Medicaid program, will largely address this issue both nationally and in California. So I think the exchange is going to be enormously successful in achieving the goal of reducing the number of uninsured Californians and in providing valuable information in the marketplace to simplify what is right now a very complicated purchasing decision for lots of people. But I think about the exchange as creating essentially an open enrollment period or process for a number of Californians who currently don't have that option available to them. So any of us who work for large employers, many of us have an open enrollment season every year where we have some choice of the insurance. But many Californians don't have that choice on an annual basis. The exchange is going to function like that unified marketplace, and I think as a result it's going to be an extremely valuable resource to people who currently don't have access.
Hildy asks, what is the progress in the design of the essential health benefits packages for Plan to California?
Well, the governor signed a law back in September saying that the Kaiser Small Group 30 plan is the benchmark for essential health benefits in California. And although I can't, I've recently looked at that plan in detail. The structure of the benefits goes on for 25 pages, so it's a little difficult for me to summarize in a couple minutes. But it's a pretty comprehensive set of benefits. So I think that I wouldn't characterize it as a narrow benefit package. It's a pretty comprehensive set of essential benefits.
Jerry, I'll ask you another question while we wait for people to type in more questions if they have them. The headlines in the newspapers today all said that the battle is over, that the president's reelection neutralizes efforts to overturn the law, and yet there's talk of challenges from the Republican-controlled House of Representatives during negotiations to cut the federal deficit later this month. What do you foresee in the way of some of those challenges? Well,
I wish that I could agree with that optimistic assessment that the president's reelection once and for all is going to put an end to the challenges. But I just don't. I don't believe that it's over. However, having said that, I think that the magnitude and the effectiveness of the ongoing challenges and efforts by states to delay implementation of the law now become increasingly diminished. At some point, even the effort right now, I think that the most effective, for lack of a better term, I'm struggling to find the right word to describe this, for states that are going to drag their feet and not implement exchanges as a way of resisting implementation of the law, the federal government's going to step in and it's going to operate exchanges in those states. So you could think about this as, you know, the equivalent of the federal government sending in the National Guard. If that's what it's going to take, the federal government's prepared to do it. I don't think that the resistance is going to go away immediately, but over the next few years, ongoing resistance to this law is going to be increasingly difficult to sustain. And I'll just give you, I think, a more concrete example. I know that there are, you know, 25 or 26 states where the governors have said that they're not going to expand their Medicaid programs because they can't afford it. I've used this example before. I think that the dynamic has changed with the president's reelection. Up until a few months ago, even prior to the Supreme Court challenge, a governor could effectively say, I'm going to resist all efforts to implement Obamacare in my state because we don't believe that the federal government should be telling us what to do. And that position would resonate with a certain portion of the population of the state and might even help that governor get reelected. Now that the Supreme Court has ruled the bill constitutional, the law constitutional, and even though the Medicaid expansion is not mandatory, for a governor to continue to oppose the Medicaid expansion in his or her state means that he or she is risking the wrath of healthcare providers in the state who are providing billions of dollars of uncompensated care. And I suspect that, you know, members of the Medical Association, the Hospital Association, and other organizations representing healthcare providers are likely to ask for a meeting with the governor and ask the governor to reconsider that principled stance against accepting federal support for Medicaid expansion, because the billions of dollars of free care that's currently being provided by hospitals and doctors and other healthcare providers. So I think the dynamic changes now, and resistance comes at a increasingly higher cost.
I should mention, Jerry, to let everybody know that Dr. Kominski will be moderating a panel discussion at the Health Forum on November 28th here at UCLA at 6 p.m. in the evening on this very topic, the impact of the election on health care reform. Jerry, I see no more questions, so I thank you so much for joining us today and speaking about this.
Thank you.
And I want to let everybody know this was a special webinar. We will have our regular webinar next Tuesday, November 13th. We'll continue the conversation with Dr. Roger Dietels, who will talk about barriers to achieving an AIDS-free generation. Thank you all so much for joining us.